rules for all delegates. This is to respect time as well as able to concentrate to active speaker. So when the speakers are speaking, please ensure that you have your audio and video both off. Now I hand over to Dr. Jaya Kuruvilla, President, CCNS. Over to you, Dr. Jaya.
Good afternoon to all of you. I am am I audible? Am I audible, Shija?
Yes, ma'am.
Yes, ma'am.
Yes.
Highly delighted to welcome all of you to this first skill-based webinar organized by Critical Care Nurses Society. After having conducted our international conference in collaboration with RFCC and SARC at KLE University, Belgaum, we are able to put together this webinar, which is skill-based, which I'm sure the participants will benefit. CCNS always believes in conducting value-added program of high standard and which is relevant to clinical situation. CCNS is ready to undertake accreditation for critical care nursing excellence with the standards, tools, and trained designated team. It is highly satisfying to note that the Safety Hospital is the first one going in for the same, setting a new benchmark for themselves and becoming a pioneer for CCNS to kickstart the venture. I'm sure others will follow their path. Let me welcome the resource persons for today's program. We have Janet Voss, nurse educator, and Yui Kanwilkar, nurse coordinator ICU, both from Safety Hospital. Dr. Charudat Vaiti, consultant intensive care and critical care, Fortis Hospital, and Ms. Sujitra Suresh Kumar, nurse educator, Fortis Hospital. A warm welcome to all of them from CCNS. I thank Ms. Belinda and Ms. Minimol Verghese for taking the lead in organizing this webinar from their end. And also to Ms. Prajakta Hindalekar, who is moderating this session. Welcome to managing committee members of CCNS and dear participants who are here because you are eager to learn, which is proved. I also appreciate the efforts taken by the semi-techie team of Hinduja College of Nursing, Ms. Shubhangi Pangam, Siman Xavier, and Chaitanya, who put this virtual session operational for us within such a short time. Lastly, after having gone through this program, I request each one of you participants who are here today to make a decision to participate in strengthening the CCNS, the Critical Care Nurses Society of India, the one and only organization for critical care nurses, by becoming the life members of the society, and also by contributing to the journal, which is going digital and becomes much easier. And after the program today, we will be issuing you the e-certificates. All the very best for the webinar. Wishing everyone a much different, prosperous, healthy, and happy new year. Thank you.
Thank you, Dr. Jaya. I'm sure the delegates are so enthusiastic, they are so quiet, and they're only going to listen to the speakers. So I'm thanking in advance that let us maintain the same discipline with our housekeeping. As you all know that NIV and high flow nasal cannula, we have become more familiar. Many of us are so used to it now. So what is it? It is an alternative method of ventilation that uses a mask instead of an endotracheal tube to deliver the therapy. I think few years ago when I was a student or staff, I never used this. But it's an advantage that this type of ventilation includes that it lowers down the hospital acquired pneumonia, increases patient comfort, and it is a most non-invasive nature of procedure that allows easy application and removal. It is indicated in respiratory failure, cardiogenic pulmonary edema, and other situations where intubation is not an option. So in today's webinar, we have Jui with us to help us understand NIV. Let me introduce you to our first speaker, Ms. Jui Jitendra Khanvilkar. She is nurse educator, ICU, Saifi Hospital. She has done her post-basic BSc, also hybrid postgraduate diploma in healthcare management. She has more than 22 years of clinical experience. I'm sure all the delegates are going to benefit what she is going to tell us, the nitty-gritties of NIV. She is member of CCNS, TNI, and she has contributed in many conferences as resource person. She also has publications to her credit. The second speaker that we are going to have explaining us NIV is Miss Janet Vaz. She is currently working as nurse educator for Saifi Hospital. She has more than 3 years of clinical experience. She has done her basic BSc nursing. She is also a member of CCNS. She has also published her study as well as articles in CCNS e-journal. So let us welcome our both speakers who are going to take us through non-invasive ventilation. Over to you, Jui.
A very good afternoon to one and all. Thank you, Ms. Prajakta Nilekar, for the introduction. I am Ms. Janet Vaz, nurse educator at Saifi Hospital, and my co-speaker is Ms. Juhi Khanvilkar, who is a nurse coordinator at Saifi Hospital. So our topic for today is non-invasive ventilation, and I'll be sharing my screen now. So the objectives of the session are, first is to define what is a non-invasive ventilation and its goals. You can see it. Just a minute. Just a moment. I'll just share my screen. Go to slide. Yeah, can see. Okay. So the objectives of the session are, at the end of the session, the participants will be able to define what is a non-invasive ventilation and its goals, enumerate the mechanism of NIV, discuss the prerequisites which are needed for success of NIV, enumerate the types and modes of NIV, classify what are the advantages and limitations, discuss the complication associated with the usage of NIV, explain disinfection of NIV post-usage, and state the nursing management of patient on NIV. So there will be a theory part and a practical aspect to our session. So as the definition states, mechanical non-invasive ventilation refers to delivery of mechanical ventilation to the lungs using techniques that do not require an invasive artificial airway. So two things you have to remember, that it is you are mechanically ventilating the patient, but it is a non-invasive artificial airway, mainly done using the endotracheal tube or the tracheostomy tube. Now there are some goals of NIV. So we'll go through that. The first is early intubation and support. So early intubation and support, why do we say it? Because non-invasive ventilation has same physiological effect as invasive ventilation. That is, it unloads the respiratory muscles, it augments the alveoli, and it improves the gas exchange. Okay, so it can be an early option to invasive ventilation. Why? Because studies have shown that non-invasive ventilation, when correlated with invasive ventilation, increases the risk of infection like VAP, increases injury to the upper airway. It can increase the length of stay of the patient, and it can increase the cost as well. The next point is it resolves and improves gas exchange. You have to remember the two main causes why we use NIV is either because it is an hypoxemia, respiratory failure, or whether it is a hypocarbia respiratory failure. So in these two cases, we use NIV. So basically, we saw this NIV. Third is unload of respiratory muscles. So basically, in this, it means that when the patient is inhaling, like conditions such as COPD, asthma, bronchiectasis, patient has difficulty in initiating a breath. So there's a lot of strain on the external intercostal muscles, accessory muscles, and inspiratory muscles. So in order to decrease those muscles and to decrease the fatigue, we are using the NIV. The fourth is decreased dyspnea. Again, if there is a decreased load on the respiratory muscles, it will reduce dyspnea. Fifth is avoid complications, mainly complications like infections, ventilated associated pneumonia, as we already spoke of. The sixth is improved clinical outcomes. When we speak of improved clinical outcomes in terms of reduced cost and length of hospital stay, reduced infection, and reduced mortality and morbidity, and overcome auto-PEEP. So first you need to understand what is PEEP. PEEP stands for positive end expiratory pressure. So it is defined as the amount of air that remains in the alveoli at the end of expiration. Certain conditions like COPD, what happens is that the complete emptying of the air doesn't take place. So there is intrinsic PEEP is high, so there is hyperinflation of the lungs. So by using an NIV, what you do is you maintain the PEEP at a regular level and you overcome that intrinsic PEEP. So these are some of the goals why we use NIV. Next is mechanism of NIV. First is reduction in inspiratory muscle work and avoidance of respiratory muscle fatigue. This is similar to what we saw in the goals, that by decreasing the workload of breathing, you are reducing the muscle fatigue. Then it improves compliance by reversing microatelectasis. So microatelectasis is basically microscopic collapse of the alveoli that is usually detected in the chest X-ray. So what it does is it causes, it augments the alveoli for improving the ventilation. So thereby reversing microatelectasis. The third is overcomes intrinsic PEEP. As I already told you, in certain condition, there is no complete emptying of the alveoli. So by using an NIV, you are overcoming the intrinsic PEEP. Enhanced cardiovascular function. So in certain cardiac cases like cardiogenic pulmonary edema, okay, you can use an NIV. So what are the benefits on the cardiac system is basically it decreases the venous return. When it decreases the venous return, it decreases the preload of both the right ventricle as well as the left ventricle, thereby decreasing the afterload and improving the cardiac function. Last is reduced CO2 production. So what it is doing, it is basically, NIV is basically augmenting the alveoli. That is, it is increasing the function of the alveoli by reducing the PaCO2 level, that is partial carbon dioxide level in the blood, thereby correcting hypoxemia and respiratory acidosis. The next is prerequisites. So there are certain prerequisites for successful non-invasive ventilation. So first and foremost is that a cooperative patient with adequate cough reflex. That means a patient who can maintain their airway and secretion and has an adequate cough reflex. The second one is spontaneous breathing. By spontaneous breathing, we mean to say that the patient should be able to synchronize his breath with that of the ventilator, and the patient should be able to breathe for several minutes, even if there is no ventilatory support. Third is hemodynamic stability. The hemodynamic stability of the patient should be maintained, or it should be within normal limits. The fourth is PaCO2 if more than 50 mm of Hg, that is partial carbon dioxide in the blood. Normally 35 to 45 mm of Hg, and pH of the blood is less than 7.15. That means the patient is acidotic. Okay, you can use a NIV, and gradual improvement within the first 2 hours. So how will we come to know that there's a gradual improvement within the first 2 hours? So you need to remember the 3 responses. First is a subjective response, the second is an objective response, and the third is a physiological response. This is similar to how you write in the nursing care plan, the subjective data, objective data, and the physiological response. So in subjective data, within the first 2 hours, you need to see near the patient's bedside monitoring whether the dyspnea has resolved and the patient is not feeling restless. That will be a subjective observation. When we talk about objective data, so you have to check the mental status of the patient. So objective data is something which you can observe. So check the mental status of the patient, the respiratory rate, the heart rate of the patient, and use of accessory muscles or not. And the last one is physiological response. In physiological response, it is basically monitoring. So monitoring of the arterial blood gases, whether it has come back to normal, and monitoring the saturation level in the blood using pulse oximeter. So these are some of the prerequisites for successful non-invasive support. Now there are certain indications for NIV. So indications can be divided into 2. You can call it as an hypercapnic respiratory failure and hypoxemic respiratory failure. First, you need to understand the difference between the two. So when we say hypercapnic respiratory failure, that means it is the inability of the lungs to eliminate the O2 from it. Okay, so lungs are unable to eliminate adequate O2. This type of hypercapnic respiratory failure is also known as type 2 respiratory failure. When we talk about hypoxemic respiratory failure, that is a failure of the heart and the lungs to generate adequate O2. So that means there is no adequate O2 generation and there is decreased O2 level in the blood itself. So this type of respiratory failure is also known as type 1 respiratory failure. Now, what are certain indications under hypercapnic respiratory failure? First is COPD exacerbation. So when you look at the pathophysiological framework of COPD, how is it? So first is the elastic recoil is gone. There is dynamic hyperinflation of the lungs. There is increased peripheral vascular resistance. Okay. So by using an NIV, what are you doing? You are overcoming the intrinsic P, how we discussed earlier, and thereby you're augmenting the alveolar, and thereby you're improving the ventilation. The next is asthma exacerbation. Asthma is a reversible respiratory condition. So NIV can be used here along with pharmacological management. The third is neuromuscular diseases. Neuromuscular diseases, there are heterogeneous group of neuromuscular diseases. So neuromuscular diseases, mainly when we see, example can be Duchenne's muscle dystrophy, it can be Guillain-Barré syndrome, it can be myasthenia gravis. So these diseases causes weakness of the muscles. So NIV can be an option along with secretion clearance and bronchodilators. The fourth one is bronchiectasis. Bronchiectasis is nothing but widening of the bronchial, irreversible widening of the bronchial, and over a period of time, because of the inflammation and chronic infection, mucus plug will take place. And the patient in bronchiectasis, what happens because of the high dilatation of the bronchial passage, patient cannot cannot cuff there's no cuff reflex, proper cuff reflex. So over a period of time, the mucus plug will form and there will be increased resistance. So in these cases, NIV can be used along with secretion clearance and bronchodilators and decongestions. Now, when we see these are the hypercapnic respiratory failure indications, now we'll go to hypoxemic respiratory failure indications. So the first in that is cardiogenic pulmonary edema. So NIV has a dual effect in this. It has a cardiac system effect and it has a respiratory system effect. When we talk about the cardiac system effect, basically what it does is it reduces the venous return, thereby reducing the preload in the right ventricle as well as the left ventricle and decreasing the afterload, thereby enhancing the cardiac function. When we talk about the pulmonary effect of the NIV, basically what it is doing, it is augmenting. Augmenting means increasing the alveolar to perform their perfusion function, thereby reducing the respiratory acidosis. So that is why one of the indication in hypoxemic respiratory failure is cardiogenic pulmonary edema. The second is post-operative surgical procedures. So hypoxemia is one of the complications of post-surgery. So it happens because there is a synergistic effect of anesthesia, there's diaphragmatic collapse, and there is the pain, post-operative pain. So NIV, after careful observation of the complications, post-op complications, NIV can be used for those patients. The third is chest trauma. Chest trauma, hypoxemia is one of the complications. Along with pain management, NIV can be used. And the last is pandemic viral illnesses like COVID-19. So there are lack of RCTs, that is randomized controlled trials on use of non-invasive positive pressure ventilation for SARS related infections. A study which was done in China, there was a cohort study which was done in China on H1N1 influenza, where the study found that use of non-invasive positive pressure ventilation led to patient failure and patients had to be reintubated, by using an invasive mechanical ventilation. But the reason why recent guidelines tell us to use an invasive, non-invasive positive pressure mechanical ventilation is because they are given some suggestive responses that if the hospital setup is well equipped, if there is a negative pressure room in the hospital, if hygienic conditions are practiced, if a proper interface is used, that is a non-vented mask is used for the patient, the non-invasive positive pressure ventilation can be used. But you have to remember that careful selection of an interface is very important in order to prevent NIV related transmission to healthcare workers. Next, we'll go on to the contraindications of NIV. So contraindications can be divided into two. You have absolute contraindications and you have relative contraindications. Absolute contraindications are those indications where NIV is a big no. So first one is respiratory arrest and unstable cardio respiratory status, where the patient is not able to maintain his airways. He cannot use an NIV. Next is unable to protect airway, impaired swallowing and cough reflexes. Again, it is a big no because intermittently you will have to remove the NIV and you will have to do suctioning. Then craniofacial trauma and burns you cannot use. Anatomic lesions of the upper airway, it cannot be used. The relative contraindication if the patient is very anxious, it cannot be used because the patient has to synchronize his breathing with that of the ventilator. The next is uncooperative patients, again cannot be used because again they'll be anxious, anxiety again, hyperventilation, and it will increase the CO2 level. Copious secretions. If there are too thick secretions, again these patients you cannot use an NIV, multi-organ failure, and need for continuous or nearly continuous ventilatory assistance. Now, types of NIV. When we talk about types of NIV, there are two types of NIV. So it is divided into two. One is a positive pressure ventilation and one is a negative pressure. So when we talk about positive pressure, this is usually delivered through a mask. So there are two main types in that. One is a continuous or constant positive pressure airway, which is known as a CPAP. This is a non-clinical mode. And bi-level or biphasic positive pressure airway, which is a clinical mode. Negative pressure ventilations were used early during the 90s, extensively, mainly during the polio epidemic. The tanks were known as the iron lung. I'll show you the picture. So what happens is in positive pressure ventilation, you are delivering directly the positive pressure to the lungs. But in a negative pressure ventilation, the patient is placed in a iron lung like this, wherein external pressure is applied to the abdomen and the thorax, and the patient usually breathes from the upper airway. The head is kept outside. But now this is an obsolete practice. This is only for your knowledge. Now, modes of NIV. There are two modes of NIV. One is a pressure mode and one is a volume mode. So, pressure modes are usually well tolerated by the patient and it is cycled. And there are two modes in that. As we spoke earlier, it can be constant or continuous positive pressure airway or bi-level or biphasic positive pressure airway. Volume modes are basically you're giving tidal volume to the patient. It is usually calculated 6 to 8 ml per kg it is being given. So for example, if the patient is 100 kg, so 100 into 6, so 600 tidal volume need to be given to the patient. So there are two modes in that, control and assist control. Mainly we'll be talking about the bi-level or biphasic positive pressure airway. So by the word itself, you can understand bi-level means two. So two types of pressures are being delivered to the patient. So inspiration is an active breathing. So one pressure is delivered during inspiration and expiration is a passive breathing. One pressure will be delivered during expiration. So inspiration, the pressure which is delivered during inspiration is known as inspiration positive pressure, that is IPAP, and the pressure which is delivered during exhalation, that is passive exhalation, it is known as the EPAP, that is exhalation positive pressure airway. The inspiration pressure has to be more than the expiration pressure because inspiration is twice that of the expiration. So how will you remember this? There is a small formula for this. BiPAP is equal to IPAP plus EPAP. And EPAP is nothing but you're just maintaining the peak. So EPAP is equal to PEEP, that is positive and expiratory pressure. And IPAP is you're maintaining the PEEP as well as you're giving pressure support to initiate the breath. Now, what are the respiratory effects of BiPAP? So what does EPAP do? So EPAP will provide PEEP. It will increase the functional residual capacity. Functional residual capacity is nothing but the amount of air that remains in the lungs after exhalation. Okay, normally it is 3 liters. It reduces FiO2 which is required to optimize the saturation. That is FiO2 is a fraction of oxygenation. That again will be set based on the patient's condition. IPAP is equal to, as we spoke, it is PEEP plus positive pressure support. So it decreases the work of breathing and improves oxygen. There is increased spontaneous tidal volume and it decreases spontaneous respiratory rate. Now, functioning of BiPAP. Now, how does the BiPAP function? It is a cyclic process. You need to remember this. So, first is the patient breathes. Okay. So, when the trigger is being identified, there is decreased air flow in the circuit. So, because of the decreased airflow, the trigger has been identified because our machines are smart machines. The Mac machines that we have, they have microchips. So, those are smart machines. They will identify the micro particles in the airway and it will generate a trigger, and because of that the machine will deliver inspired positive pressure airway and provide a tidal volume. Then when the patient exhales, the machine will identify and then will deliver the preset EPAP to maintain the peak. So you just have to remember the cyclic process. Patient breathes, there is decreased airflow in the circuit, machine will deliver inspired tidal the volume, patient will exhale, and machine senses that and will deliver the EPAP. Now, what are the advantages of non-invasive ventilation? First is intermittent ventilation is possible. One of the prerequisites is what? The patient should be able to breathe, unaided for several minutes, even if the ventilation is not being given. So intermittent ventilation is possible. Patient can eat, drink, and communicate. Why? Because intermittent ventilation is possible. It is ease of application and removal that will be shown in the practical
Ma'am, not audible, ma'am.
Janet, are you there? I think you're not audible, dear. Janet, are you adjusting your audio, dear? You're not audible now.
Just a minute.
Okay, now
you
we
hear
can
now?
hear you. We
Now
can
you can
hear.
hear? Okay,
Yes,
okay.
yes.
Thank you. Okay, so have you missed out on any points? Hello?
Advantages.
Advantages. Okay,
The
thank
last
you.
slide was advantages, correct?
Yes, yes, thank you. Just a minute. Okay. Okay. Am I audible now?
Yes, please go ahead,
Okay,
Janet.
thank you, thank you.
Yeah.
So advantages of NIV. First is intermittent ventilation is possible. As I told you in the prerequisite that one of the prerequisites is that patient should be able to breathe for several minutes if ventilation is unaided. Next is patient can eat, drink and communicate because you can provide it intermittently. Patient can eat, drink and communicate. There is ease of application and removal. My co-speaker will be demonstrating it, how easy it is and how do you remove it. Improve patient comfort. It is very essential to tell to the patient that how do you synchronize your breath with that of the ventilator. So there is improved patient comfort, reduced need for sedation. So when you look into invasive mechanical ventilation, there's an increased need for sedation. But for NIV, there is a reduced need for sedation and correction of hypoxemia without worsening hypercarbia. Hypoxemia is nothing but decreased O2 in the blood, especially in the arteries, and hypercarbia is nothing but excess of CO2 in the blood. Limitations. So limitations of NIV is divided into three. That is system-based, interface-based, and airway-based. So when we talk about the system, it is the patient as well as a multidisciplinary team. So in the system, the first limitation is slower correction of gas exchange abnormalities. As I spoke earlier that in the prerequisite that there should be gradual improvement for the patient within the first 2 hours. If that correction doesn't take place, that means the patient selection was inappropriate, the monitoring was inappropriate. Okay, so that means this patient there's a predictive failure of NIV. So that is a system failure. Next is time commitment and attention. Time commitment, attention in terms of you require proper skills. So you require adequate skills in terms of doctors, nurses, respiratory therapists, and attention you require at least for the first 2 hours, half an hour, every 15 minutes, and then every half an hour you need to monitor the patient. Gastric distension is another system-based limitation. Gastric distension occurs if the patient swallows the air, which is known as arophagia. Excess air will lead to irritation of the gastric contents and it will lead to aspiration. When we look at limitations of interface-based limitation, when I talk about interface is basically the mask that we are talking about. Okay, so leaks. If an appropriate size of mask is not selected, if the strips are not adequately tied to the patient, there can be leaks. So this will be dealt in the later part of the session. Next is skin necrosis and rash. If the mask is tight fit, it can lead to skin necrosis and rash. Eye and ear irritation. Leaks can cause dryness of the eye, and if the straps are above the ear, it will cause irritation. And if the mask is too tight, it will increase the sinus pressure and cause sinusitis. When we talk about the airway, mainly aspiration, as we spoke here, if there is arophagia, too much swallowing of air, gastric distension, it will lead to aspiration. Then that patient has to be put on NIV. And airway again, limited secretion clearance. You cannot intermittently remove and do the suctioning. So there is limited secretion clearance. Now complications. So complications are taken from a study published in New England Journal of Medicine in 2015 by Kelly C. and al. So they have given the list of complications as well as the suggestive responses. So first is the air leak. So in that they say that you have to ensure that the mask is of correct size and fit. Thus tighten the straps, reduce the pressure if possible if there is an air leak. The second is skin irritation and abrasions. So apply skin protected devices according to your hospital protocol. Third is claustrophobia. So this can be prevented. First and foremost, it is very essential that you explain the procedure to the patient prior to initiation of the therapy. And if too claustrophobic the patient feels, light sedation can be given. The fourth is nasal congestion, sinus pain or ear pain. So provide topical decongestants or antihistamines if not contraindicated, and humidify inspired air. That when we apply an HME filter, that is heat moisture exchange filter, you humidify the air. That will be demonstrated later. The next is mucosal dryness. Again, you need to apply the HME filter to humidify the inspired air. If there's a mucus plug, humidify the inspired air and chest percussion and suctioning if possible. Pulmonary barotrauma or pneumothorax is there, you need to stop the ventilation or if possible reduce the air pressure and insert the chest tube if applicable. Now, what are some of the predictive failure of NIV? Okay, first is when you're unable to reverse the underlying cause of the disease. That means there's no improvement in the patient. As we told, you have to see for three responses, that is subjective, objective, and physiological responses. If that is not being reversed, that means the underlying cause is not being treated. So that means there's a failure of NIV. The second is unable to correct acid-base balance within the first 2 hours. There's no improvement in the gas exchange. Third is persistent hypoxemia, which again can be seen in the ABG analysis report. Hemodynamic, the patient is deteriorating hemodynamically. Altered mental status, endentulus. Endentulus is basically lack of teeth, and studies have shown if the patient is endentulus and is lean. So what happens, especially in old age, if there is no adequate mass on the face, the increased leakage takes place and there is predictive failure of NIV. Excessive secretions again will lead to NIV failure. Inability to tolerate the interface. The patient is not able to synchronize his breath with that of the ventilator, then it will lead to failure of NIV and older age. So now my co-speaker will demonstrate on the practical aspects of NIV.
Good afternoon, everyone. Thank you, Janet, for highlighting us on theoretical aspects of non-invasive ventilation. Now, I will be speaking on practical aspects of non-invasive ventilation. So, as you know, as we nurses, we are the most important people in the hospital setting, as the patient is to be put on BiPAP. So, doctor will come and he will write the order saying that we put the patient on BiPAP and he will go away. We will just write the settings and he will go. But later on, the whole responsibility remains with us, that we have to take care of the patient throughout the day and night about the ventilation of the patient. So I will be showing you how to use the BiPAP and how to apply the BiPAP machine on the patient face. So portable BiPAP Below 50, which we have in our hospital setting, it has got invasive mode also and non-invasive mode also. So I will be telling you about the non-invasive mode of ventilation on this BiPAP. This is the BiPAP machine Below 50 which we have. This is the screen of the BiPAP machine where all the setting will be done. And then the attachment has to be done by us. This is the side of the machine. This is the expiratory oxygen source where we can apply the oxygen tubing and patient can be given oxygen. This is the expiratory port of the breathing circuit where we will put the breathing circuit. Then the power cord has to be applied to the main supply point, so that the machine can work, and even it can be work if you are transporting the patient anywhere. So if it is enoughly charged, patient can be transported with the BiPAP. Then the switch on and off button here, black color, which has to be put on. Then articles required for the BiPAP. The first thing is breathing circuit that is to be put at the expiratory port. Then the BiPAP machine hole, the oxygen tubing, then the mask. This is fenestrated mask or non-vented mask, which we call. It has got two exhalation valves. Since this BiPAP machine do not have inbuilt exhalation valve, it has got two holes for exhalation, and there is one valve which will prevent the backflow of the air deflection. Then buffet head cap has to be kept for the patient. This is HME filter, heat, moisture and exchanger filter. It will help in giving humidified oxygen to the patient, and it will trap some of the microorganisms also. So it may prevent infection. It will prevent the healthcare professionals from getting airborne infection. Then the skin protecting devices as per the hospital policy. Then before starting the BiPAP machine on patient, it is always mandatory to have a pre-use check. Once the pre-use test is completed successfully, you can start the machine on the patient. So first you attach the oxygen tubing to the oxygen source. Keep everything ready so that you don't have to run for the articles. Then the expiratory breathing circuit has to be attached to the expiratory port. This is a single tubing. You can attach it to the expiratory port. Fix it tightly. Sometimes it can become loose and it can disconnect, which means you may not come to know. So see that it is fixed properly. Then power cord, attach the power cord and switch on the button. Put the machine on. Now check the monitor for the setting. This is the monitor screen of the BiPAP machine. Now the screen itself will tell you how to do the pre-use check. You have to read the instructions and do the pre-use check test. When it tells you, when it's checking the patient circuit, it will tell you to block the end of the patient circuit. So other end, which is free, that you can block it with your hand, and the pre-use check can be completed. Once the test is completed, the screen itself will tell you that all the tests are passed, that is leakage, resistance and compliance tests are passed, and now the machine is ready to use. So this is the way pre-use check has to be done before each use of the machine to the patient. Then this is the screen of the monitor where you have to do your setting. Now we will go for a mode setting. This is how we will set the modes. There are two modes here: pressure support ventilation and CPAP mode. So we are in a hospital setting. We are using pressure support mode of ventilation. So as I putting my finger on buttons, it will go as a green screen which will tell me which mode to select. So I will select pressure and then I will select the support mode of ventilation. Once all it is done, I will select the mode and the machine. I will start the machine on the patient. You have to check all the parameters clearly. Now these are the IPAP and EPAP setting, which already discussed by my friend Janet. That is inspiratory pressure and expiratory pressure. The machine it has got is by default setting of 12/6, but we can set the IPAP and EPAP as per the patient's clinical condition and patient's ABG parameters and even the respiratory rate of the patient. So here EPAP we can set normally by 12 and we can increase or decrease as per the patient's clinical conditions. Even all these parameters, the respiratory rate, the tidal volume, the backup inspiratory time, everything will be set as per the patient's clinical condition and the ABG report which we have done before putting the patient on machine. Then if you can see there one man and there is one straight connection you can see on the screen. It is showing that the patient, we are putting the patient on BiPAP. As I told you before that this is also got invasive mode of ventilation also. So when I am selecting the mode, this leakage is the mode of BiPAP. The exhalation valve is the mode of invasive ventilation. But here we can give invasive ventilation only up to 60% of the FiO2. So here I am using BiPAP mode of ventilation. So here I am selecting the circuit type. Since I have a single circuit, So I will select the mode as leakage mode, which will give me only non-invasive ventilation. I have to confirm the circuit type and I have to go for the mode selection. Once it is done, my settings are done. Now I have to go for the mask fitting to the patient. Alarms has to be set as per the patient's parameter. Now you have to start the ventilator or BiPAP machine on the patient. The graph will appear on the screen and we can monitor the patient when the machine is in use. Now, as a nurse, application of mask to the patient is very, very important. That if the mask is not fitted properly, it will give risk to it is a risk to the patient. So how to apply mask is very, very important. So here for this BiPAP, I will use vented mask or fenestrated mask. Since these masks are expensive, we cannot open it immediately from the packet. The masks are available in different sizes. You check the marking on the mask, the measurement is given on the mask. Before putting the mask on patient, you please speak to the patient and explain the procedure to the patient so that you can gain their confidence and reduce their anxiety. You can explain how it will benefit to them and it will reduce their hospital stay. You measure the mask, putting that marking on the patient's in outer canthus of the eye till the lower lid and see which size of mask is fitting to the patient. Once it is done, you see the strap of the mask you keep at the back of the patient's head. It has to be fixed properly. Before that, you keep the put the front cap to the patient so that you can protect hair, and the mask straps also will be fixed properly. Keep the patient in Fowler's position. It will help in easy inspiration and expiration. And also when the patient is breathing, he will breathe by, he will try to breathe by mouth, thinking that machine is doing everything. So, and there will be excessive swallowing of the air, which will lead to gastric irritation and distension. To prevent that, and it will lead to aspiration. To prevent that, the patient should be in 60 to 90 degree Fowler's position. This is the way we can put the strap at the nape of the neck. Keep it properly so that the mask can be fitted properly. The mask has three connections, two from the side and one from the above the head at the on the level of forehead. The mask can be fitted. See, duodenum patch or skin protecting devices as per your hospital policy can be put over the nose bridge, completing full on the nose bridge, nasal bridge, and you can put it on the two strips can be put it on the cheek also to prevent MARSI. MARSI, as you know, it's a medical devices related skin injury. To prevent that, you have to apply that patch on the skin. Once you fix the mask on the patient's face, put the strap properly till you get the click sound when you put the straps. It has got a clip. So you have to fix that strap clip on the mask connector and it will give you click sound. From both the sides, you first clip it properly and then put the upper strap on the forehead. When you are putting the side strap, you see that you are taking it from below the ear and not above the ear, because it may again cause pain and irritation to the ear. So it can be taken below the ear. Once the mask is fit, see that the straps are 2-finger loose and it is not too tight to the patient, and it should be taken below the ear. See that it is loose but it is perfectly fitted on the patient's face. There is no air leak from it. Ask the patient whether he is comfortable after putting the mask. And in between, you can communicate with the patient so that patient will not have any anxiety or she will be communicative throughout the procedure. Once the fittings have been done, go to the BiPAP machine, check your settings again, check your parameters, and start the ventilator, start the machine. Be with the patient throughout it for some time, because we should know and when we put the patient on BiPAP, patient is improving with the pressures which we are giving. Now you can see in the picture, this face is showing us how to measure the BiPAP mask from the outer canthus of the eye to the lower lip. Then the packet, it has got the measurement picture, and these are the different sizes of mask. The blue color is non-vented mask, which is usually used in a ventilator, invasive ventilator, where they are having inbuilt NIV mode. And the white color ones are the non-vented or fenestrated mask, which has got exhalation port and the wall, airway pressure wall. They are available in 3 sizes: small, medium, and large. As per the measurement, we have to apply. In Indian scenario, all the patient mostly they use small mask. Female nurse patient small mask, and the male usually they use medium mask. The large mask becomes very large to the Indian faces. Now there are some tips how to apply the mask. The mask fitting is very important. So when you explain the procedure to the patient, you explain the patient the modality, how it will help to the patient, and how it will prevent from endotracheal intubation. So to assure them and to put the mask properly is very important, and being with the patient till the patient is properly. You have to hold the mask in a place until the patient is comfortable. And when you start the ventilator, the patient is breathing and he is synchronizing his breath along with the ventilator. Two finger passage should be there to prevent any skin irritation and to prevent tight fitting of the mask. Then skin patch has to be applied to prevent any abrasions or necrosis to the nasal bridge and on the face. The head of the bed should be elevated to avoid aerophagia and also to maintain normal breathing pattern and to prevent tachypnea. See, now whatever I have told is about the BiPAP machines which all hospitals are using. Now I will switch on to Servo-Mackey ventilator. We have this is the invasive ventilator, but in our hospitals we have inbuilt mode of a non-invasive ventilation in these ventilators. So if the patient is, if we do not have enough BiPAP, also we can directly use Mackey ventilator which has got an inbuilt NIV mode in it. So this is Servo-I Mackey ventilator hole. This is the back side of the ventilator where there are 2 tubings, oxygen tubing and the compressed air tubing. So this is the attachment directly to the ventilator. The white color tubing is oxygen supply and the black color tubing is compressed air supply. You have to just push the knob inside those connectors and it will get fixed. Check that it is fixed properly. If the connections are loose, patient will not get proper air supply. Then when you remove, you have to push it up and then pull it down. It will easily come out. Then there is a black filter which has to be changed every 3 months by the biomedical engineer. Now this is the universal air supply points, oxygen point, and the white color is oxygen point and black color is air supply point. The connection has to be fixed properly. Now here articles are same as required for BiPAP. Only since it has got exhalation wall inbuilt, we have to use non-vented mask and remaining settings will be the same. And the proper breathing circuit we need. This is the breathing circuit. Before starting the ventilator on any patient, pre check has to be done. This is the pre-use check. There are total 11 parameters which checks whole inside part of the ventilator, once including the ventilatory cassette. When all these 11 parameters are passed, when the test is passed, then only the machine can be used. Sometimes in an emergency, we don't pass the test and we directly start it on a patient. But then after some time, it gives troubleshooting to the patient. So it is mandatory to do pre-use check before starting the ventilator on patient. So after passing all 11 parameters, the machine is ready to use. Then mode setting. Here there are 2 modes in this monitor. See here on this monitor, you can see there are 2 modes. You can see now this ventilator is on invasive mode of ventilation. When I change it to NIV, now this screen is showing invasive mode of ventilation. When I change it to NIV, it will turn to orange color. Now we are in NIV mode of ventilation. There are two modes of ventilation: pressure control mode of ventilation and pressure support mode of ventilation. Initially we put the patient on pressure control mode of ventilation. So pressure control mode is the actually control mode of ventilation, where the patient will on and off, he will breathe and the machine has to support the patient. So here we have to set the parameter as P, pressure control above P, the respiratory rate, the T rise time, the oxygen concentration, and IE ratio. So pressure control above P has to be start from the minimum level, because we want to see how best the patient is tolerating the mode. You can start it with 5 and you check, see that the patient, the minimum requirement of the patient to the patient. Then respiratory rate you can fix as per the patient's respiratory level, how tachypneic the patient is. As per that you can set the respiratory rate. The IE ratio is 1:2, since we have to give enough time for the patient to exhale the amount of inspired amount of pressure. So IE ratio is always kept 1:2. The T rise time is to be kept as per the patient's again parameters. It is a time of length of time taken to initiate the breath. So you start it from 5 to 6, and then you see how better the patient is tolerating. If it is kept low, the patient peak airway pressure will go high and patient will go into trouble. So you start with the 5 and you adjust as per the clinical condition and ABG reports of the patient. Now this is pressure support mode of ventilation. Here this mode is almost manual mode, where patient will initiate his own breath, and if the patient is stopping his breath by any chance then the machine will support him. Here the setting will be the same as like pressure control. The end inspiration will be kept at 50, because we want the patient to inspire and expire the equal amount of air, so to prevent CO2 retention. So here this mode is well tolerable by all the patients, and it's a winning mode to the patient. So this is the best mode for the patient. You can see this is pressure control mode of ventilation graphs. You can see patient is inspiring and expiring. Whatever set parameters are there, they are properly shown in the graph, and the patient is tolerating the mode very well. So whatever set parameters as per the patient's ABG report, X-ray, chest, and even the clinical condition what we have seen, it is matching with the graphs. So this patient is tolerating this mode very well. And oxygen concentration you can decrease or increase as per the saturation level of the patient. And you have to keep the patient monitoring throughout the machine, so that you don't miss on anything. Here set parameters. Here this patient is having 35% of oxygen, PEEP of 6, which is well more tolerable by him, respiratory rate of 14, and the PS above PEEP is 5. He's generating tidal volume inspired of 400, and he's expiring also that much. So he is improving. You can see in between the pink color T, that means he's triggering. So patient himself also trying to initiate his breath. So that is a good sign that patient also start trying to take breaths. This is the pressure support mode of ventilation. Here you can see mostly the straight line, because here 90% of the work is done by the patient himself. So when he stops taking breaths, the machine will push the pressure and the patient will deliver the breaths. You can see the inspiration and expiration is happening 50-50%. That you can see on the graph. And the pressure volume which is given, the patient is generating volume up to 700. That much is shown on the graph. So again, this is a well tolerable pressure support ventilation. Now alarm setting. The alarms are very important on these ventilators. So there are two types of alarm. One is high pressure alarm and second one is low pressure alarm. When you will say, you can say that there is high pressure alarm. There are 2 to 3 things which we have to see and watch and observe closely where the machines will give high pressure alarm. When you have fitted the mask and everything is going well, in between, if you see the ventilator is giving alarm and you see the peak pressure airway is going very high, you have to think of high pressure alarm. In that case, you have to check your tubings, you have to check your patient physical condition and assess the patient physically. You see that if there is any mucus plug in the oral cavity, even if it is an intermittent ventilation to the patient, sometimes due to continuous pressure, there are drying of mucosa and there are chances that patient gets mucus plug, and that mucus plug can block the airway and the pressure may not be delivered properly through the lung and it can get obstructed into the airway and patient can have high resistance. That this is the way the high pressure alarm will come. Secondly, when everything is okay, but then there is some kinking in between the circuit, which will cause resistance again, and the patient will not get proper pressure, and it will give high pressure alarm. Or sometimes because of continuous pressure, there will be condensation of and there will be water logged in the breathing circuit, and it will cause high pressure alarm. Same way, there will be low pressure alarm also. So low pressure alarm usually will come when the patient by himself has touched the mask and he has made the fitting loose and there is leakage from the mask, or while doing any nursing procedure or whatever, patient is moved and the circuit is become loose or connection have become loose and there is continuous alarm, low pressure alarm, and the patient is becoming tachypneic. So that will be your low pressure alarm. So this alarm is very, very important. As a nurse, we are not supposed to ignore the alarm. You attend the alarm, and if you find any abnormality, immediately inform the doctor and correct it. Same alarm setting for pressure support. Now, when you want to put the patient on NIV support, see, this is the ventilator where there is one inspiratory inlet and expiratory outlet. So breathing circuit has to be attached to the expiratory port and the inspiratory port, along with the HME filter. This heat moisture exchanger and filters are attached to the inspiratory and expiratory port of the ventilator, along with the breathing circuit. These ports give humidified oxygen and also it traps some of the microorganisms. The application is same as BiPAP mask fitting. You have to be with the patient and observe the patient. These articles are this cleaning and disinfection. Usually, since this NIV is used continuously and for many days to the patient, intermittently we have to disinfect the BiPAP tube, this breathing circuit and BiPAP mask. So in our hospital, we wash it with soap and water and we keep it in a Sidex for 20 minutes. After 20 minutes, again we clean and rinse under running water till the smell of the Sidex goes off, and then we keep it for drying, and again we use it for the same patient. It is a single-use devices, but you can use for the same patient for 1 month also. Then the ventilatory cassette, it is a single cassette which has to be disinfected as per the manufacturer recommendations. Thank you.
Thank you, Jui and Janet. Janet, you have anything more to share?
Yes.
Okay, because
So now just 5 minutes. Now we'll be dealing with the nursing management for patients on NIV. So what care plans will you write? So whenever you are writing a care plan, for intervention has to be in the following way. You have to remember the 3 T's. Okay. So first is take, next is treat, and third is teach. So your interventions need to be like that. Take is something that you're doing assessment. Treat is something you're giving to the patient, and teach is the health education. So in that way, you can write intervention. So some of the nursing care plans that we have listed are impaired spontaneous ventilation related to respiratory muscle fatigue as evidenced by adventitious breath sounds. So first that is assess the client's respiratory rate depth pattern, including the use of accessory muscles, assess the skin color, examine the lips and nail bed for cyanosis, monitor the oxygen saturation using a pulse oximeter, monitor ABG analysis as indicated, maintain the patient in high Fowler's position as tolerated, encourage deep breathing and coughing exercises, and you'll assist the patient in putting the NIV as indicated and monitor. Next is ineffective airway clearance related to decreased energy and fatigue as evidenced by abnormal breath sounds. So you will observe the color, odor, quantity and consistency of the sputum. You will auscultate the lungs for presence of normal or abnormal or adventitious breath sounds, and monitor the O2 saturation of the patient and ABG analysis. Administer bronchodilators as indicated. Adequate fluid has to be taken to loosen the secretions and perform chest PT as indicated. Now, anxiety can be there for patients. So anxiety related to unknown outcomes as evidenced by restlessness. So first you assess what are the signs of anxiety. You reduce the distracting stimuli for the patient. You have to inform the client about the alarms on the ventilatory system so that he doesn't panic when there's an alarm in the ventilator. Provide relaxation techniques, encouraging visiting by the families and friends, and use of communication chart if impaired communication is a problem. So there are some modalities that we use at Saifi Hospital for COVID-19 patients to reduce anxiety. So first is a communication chart. So since these patients cannot communicate and there's a mask on the face continuously, so this is a communication chart we use at Saifi Hospital for NIV patients. Wherever what are their needs, we just show them the chart and they will tell us what needs are being required and what needs to be done. Next is, this is a sticker for PPE. So when you wear PPE, you don't identify who the person is. So this is a sticker we care for you, wherein you write the name and your designation. So when you go to the patient is aware whether you are a staff, whether you are a helper, whether you are a doctor. So this will reduce the anxiety because patient will identify you by the name. And we have a smiley for you because patient cannot see the facial expression. So we have a smiley on the sticker for the same. Next is at Saifi, we have something for the COVID-19 patient, which is known as the empathy group, since the family and relatives cannot come and meet the patient directly. So we have a team of nurses and doctors who go and visit patients on daily basis and provide psychological support. Okay, we don't, this team doesn't talk about the clinical, from the clinical aspect point of view. As the relative speaks to the patient, this team daily visits the patient and provides psychological support. There is something else also that we provide, that is a music therapy for patients. So individual Walkmans are there, which is being disinfected and given to the patients. Then the fourth care plan can be risk for impaired skin integrity related to use of mechanical devices. So there you assess the overall condition of the skin. You evaluate the patient's awareness of the sensation of the pressure points. Then use of objective tool for pressure ulcer risk assessment. So we are using the Braden scale at our setting. Use of appropriate skin protective devices. We use the deodermal patch and check frequently the fitting of the face mask. So 2 fingers passage should pass. So in conclusion, I would like to say it is very important that careful patient selection has to be done. So you need to identify the indication and contraindication before selecting the patient. Skilled initiation and application. So the person should be skilled in applying also and initiating the therapy also. Algorithmic approach, that is initiation, use and discontinuation. When do you start? When do you continue, intermittently stop, and when do you discontinue? Patient comfort is very essential. Avoid dysynchrony. So it is very important that you inform to the patient that he has to breathe along with the ventilator, and avoiding complications, the complications which we have seen, and the suggestive responses. And most importantly, the clinical decision has to be made when to switch from non-invasive to invasive mechanical ventilation. So there is a modality of care for COVID-19 patients that we follow, that is the proning of patients. So there's a small video clip that I would like to show.
So we are turning the patient in a prone position. This is before turning. We have made the patient lateral at the edge of one side of the bed, and now we'll be proning the patient. This proning will be at the call of Amina, our respiratory therapist, who is holding the neck and the tube. The neck and the tube both have to be turned simultaneously. Okay, so now Amina, you can give your call and everybody will turn the patient in a prone position. All parts, pressure points will be padded. So 1, 2, 3, yes, done. All connections and everything have to be made. So now the patient is prone. We are padding all pressure points. the pressure on the tube has to be checked with the pressure before giving the position and pressure after giving the position. This pressure I'm talking is about the peak pressure. Now we have to make all the connections, including the ECG, pulse ox, arterial line, even the sole of the foot and the foot. Wherever there is pressure points, we have to keep them padded.
So this
Okay, thank
modality
you.
of care is also given for patients on bypass. So we are done with the session. If there are any questions, we would like to answer.
Thank you, Janet. And if you can stop sharing your screen, Janet.
Yeah.
Thank you, Janet and Joey, once again. And I'm sure the delegates were so glued to screen, we didn't have any disturbance during the session. And CCNS believes to be in current, and I'm sure the session, which was wonderfully taken by Joey, she went step by step. She also explained us the graphs. So every nurse that is attending today's session, will have more confidence and going to NIV graphs, understanding the patient needs, and I would say that instead of taking care patients on NIV, we will suggest that yes, this is the patient who is meeting the criteria which we just was beautifully explained by these two. And I'm sure that the delegates will be more, I would put it this way, that device dexterity. Few years ago, our teachers have taught us that we have to have manual dexterity, but it is the need of the hour, because all these devices are helping our patients get less, to be in comfort and yet meet their crucial needs. So device dexterity will only come by understanding the devices well, how to handle them, and how to even monitor patient, how to interpret the need of either escalating or the device is no more required. It's all very, very important. So as you know that CCNS believes to be in current, we have our next session, which is on high flow nasal cannula, and I have privilege in introducing the team of Mulund Fortis. We have Dr. Charudat Vaiti with us. Dr.
Yeah.
Charudat Vaiti is MD, DNB, MRCP, ED, and IFCCM. He is currently Associate Director, Fortis Hospital, Mumbai, Locum Associate Specialist, St. George NHS Hospital, London. He's got affiliations with Royal College of Physicians, London. He's a member of European Society of Intensive Care Medicine. He's also a member of Faculty of Intensive Care Medicine, member of Indian Society of Intensive Care Medicine, and his area of expertise is difficult ventilation, ECMO, and transplant intensive care. I'm sure the delegates are going to benefit from his expert skills, which he's going to share during high flow nasal cannula session. We welcome you, Dr. Charudat. Over to you. I'm sorry, I have privilege to also introduce Ms. Suchitra Suresh Kumar. She's a nurse educator, Fortis Hospital, Mulund. She's done her master's in critical care nursing from LT College of Nursing. She's got 3 years clinical experience from Lilavati Hospital. She was honored as IPSG Goal 1 champion at Mulund Fortis Hospital. She is coordinator for NRP, NALS and PALS. She's been speaker for various webinars and conferences. So in the next session, we are going to hear Dr. Vaiti and Ms. Suchitra. Over to you, Dr. Vaiti.
Thank you, ma'am, for such a kind intro. I'll just share my screen, okay? Just give me a second. Are you guys able to see the presentation?
Yes, we can see, doctor.
Great, great. Yeah, thank you. Okay, so I've been asked to
Request all the delegates, please
I'll just
unmute
request
yourself.
everyone else to mute themselves. Thank you. So yeah, I've been asked to talk about HFNC. So it's like a hot topic, with the COVID going on, and I'm quite excited to share my views and review the principles behind it for everyone's sake. Okay, so thank you for asking me to do this topic. So I want to actually share a couple of cases before I come to the topic. These are before the COVID time. So basically I'm using this to highlight that this particular device, though it has been into the limelight recently, it is it is not something new. It has been there before as well, and we have used it in the past as well. So these two cases, I just want to highlight how it can be used, and then go on to the principles behind it. So we had one 51-year-old female who was transferred from an outside hospital with 10 days history of cough, fever, breathlessness. So again, reminder, this is before the COVID existed, so it was not COVID. And she was transferred on BiPAP and was quite hypoxic. And we look at something called as PF ratio, that is PaO to FiO2 ratio, and this was less than 100 or 106. So it will categorize it as severe ARDS. So she got semi-electively intubated at that time, as there was no improvement on the NIV and there was a decreased GCS at that particular time. Post intubation, she continued to have a high FiO2 requirement and low PF ratio. She underwent HRCT on the following day. This was the X-ray, terrible looking ARDS looking X-ray. And this was the CT scan, which you can see that there's not much lungs visible. This is at the level of the left ventricle, and just at the bases really, so not much lung visible. This was at the mid level, some pathology seen here, but mostly the pathology was towards the base. So even though she had persistent high FiO2 requirement, we decided, as she was looking otherwise comfortable, that we will extubate her, because the ventilator was not providing great advantage, and we decided that we'll trial her on HFNC, or a high flow nasal oxygen therapy, which is what it is also called. And she continued to require some high oxygen, but we managed to extubate her. Then we were able to wean her off the HFNC, and we had added her steroids that time, as there was what you called it as an organized pneumonia. And this basically case highlights that early extubation is possible, even though the patient is hypoxic. It is possible to extubate them onto HFNC, because HFNC can provide uh, the oxygen and the PEEP required to sustain. So that is how it helped. And this was the CT scan at the time of discharge, the lot of clearance. So the pathology got corrected eventually, but we didn't really have to use the ventilator. So early extubation, ventilator free days, early recovery, that was the case highlight. Second case, 48-year-old, no previous comorbidities, presented with 4 days history of fever, dry cough, breathlessness, tachypnea, hypoxic on BiPAP. She was on 80% oxygen and saturation of 90% on BiPAP. CT was done outside, which was reported as consolidation versus pulmonary edema. We did an echo, which showed a moderate ejection fraction. We did the usual things, antibiotics, diuretics, non-invasive ventilation, but did not really improve, and not she this lady was absolutely not comfortable with the BiPAP. All her cultures were negative, even the swine flu, which was the things to consider before COVID. We repeated the HRCT, and this is how it looks. And what we see here is that this subcutaneous air pockets we are seeing, because the BiPAP was causing some injury to the lungs and causing the leak. So we got a pneumomediastinum and subcutaneous emphysema. So the BiPAP was actually causing harm and no benefit. Okay. So this is how the lungs were looking, terrible and quite severely hypoxic. And this time the CT is, reported as ARDS or pulmonary edema or allergic alveolitis. These were the differentials. So if you look at the Berlin definition, as I just said, this she would be categorized as moderate to mild. And this particular situation, the evidence says that you intubate. In fact, the chest physician asked us to intubate this patient. But let's think about this. And you know, these were the opinions really: advise, intubate, ventilate, bronchoscopy, unsure of using steroids, maybe do a high pulse. So different kinds of opinions. And we were in this dilemma of whether to intubate, not to intubate, really. But then we said we'll give a trial. This is how the patient looked, 24 hours after the HFNC. She was still on fair amount of oxygen, but fairly comfortable having her meals with the machine still on. And we gave her a pulse of methylpred, and she steadily improved, eventually discharged home. So this particular case, it highlights that we could avoid intubation. The first case was early extubation, and the second was avoiding intubation in somebody who's in moderate to severe category. So what is all this about, high flow oxygen therapy or high flow nasal cannula, HFNC? So what are the basics here? What are the basics here? So, it, when we breathe normally, uh, what is our inspiratory gas flow? Uh, if you have an answer in mind, you can you can just look at this, that it is up around 15 liters. Okay, so when we are breathing in and out, our gas flow is around 15 liters. But when we exercise or we are in distress, what do you guess would be the gas flow? It would go up to 120 liters. That is huge jump, from 15 liters you go up to 120 liters. I want you to keep this in mind, because that actually uh, is will help you understand the principle of the HFNC, which is because it is a high flow nasal cannula. So the flow is important. So when we are having normal life, normal this thing, our flow is around 15 liters, breathing flow. And when we are exercising, or when we are in distress, we are having a flow up to 120 liters per minute. So the other physiological things to keep in mind is that the air is warm and humidified in the upper airway, and during the respiratory distress, warm gases, they will increase fluid loss, they will increase metabolic oxygen requirement. Okay, so these things are interrelated: increased fluid loss, increased O2 requirement, and the warm gases during the distress situation. So respiratory failure is distressing for the patient, and what treatment modalities we have, and whenever we see a patient in distress, either we have got a non-invasive modalities, that is the BiPAP, which can cause the airway to dry up, or and it also has a tight fitting mask which can be very, very claustrophobic. And the second option is invasive ventilation, which has its own problems, like you have to sedate the patient, paralyze the patients, WAP, etc., etc. There are a lot of things associated with it. It's an sort of extreme step, so to say. So, how can we provide oxygen during an hypoxemic state? So you've got something called as fixed performance devices, where the oxygen which we inspire, that is the FiO2, fractional inspired oxygen, is constant despite the change in the inspiratory flow rate. Okay, so this will deliver a fixed amount of oxygen. So this, the example is the Venturi mask. The Venturi mask, you have this, it has a number written on it saying that how much oxygen is going to get delivered, no matter whatever the flow rate you keep. Okay, and the principle is that you've got a large aperture and you've got a small aperture from where the A is written. Oxygen is being driven through into this chamber, the chamber B, and as it drives through, it will suck in the air, and this gets mixed up, and you get a fixed proportion of pure oxygen and air, giving you a fixed inspired oxygen. Okay, so that is how the, and depending on the size of the aperture, the mixture can be changed. So this is something I want you to remember, because it will help you in understanding the HFNC principles. Now, variable performing this devices, the actual FiO2 will depend on what is the inspiratory flow rate. So how fast you are breathing, what is your work of breathing, that will define how much oxygen you are actually going to breathe in. Okay, so you've got nasal prongs, so you may keep 2 liters, 4 liters, but if the patient is breathing at a rate of 10, 15, then his oxygen which is inspired may be better than somebody who is breathing at a rate of 30, 35 with the nasal prong, because from the nasal prong you are getting pure oxygen, but it is getting mixed with the air which is there, and depending on how much is your respiratory rate and the inspiratory flow rate, this mixture will vary. Okay, so nasal prongs, comfortable, they are comfortable, less claustrophobic. You can go up to 4 liters on that. Then you've got the face mask, which is, we should use with flow rates of no less than 5 liters. Then you've got the NRBM, that a non-rebreather mask. You can go on the flows up to 15 liters on that. Okay, and it is a preferred, and it's just basically called as a low flow system. So now coming to the high flow nasal oxygen therapy, it is increasingly now with the COVID, actually it has been used extensively, and people have got a lot of exposure to how where it is being used, and it can be used at ward based and ICU for respiratory failure, and it provides warm humidified gas up to 60 liters per minute, and the oxygen which you can deliver is up to 100%. That is the FiO2. That is a good thing about this. So that is the basic difference between the low flow systems which we just saw and the high flow nasal oxygen therapy. So what equipments we are having here? We got a wide bore cannula which fits in the nose, and there is a long tubing which is attached to the humidifier, and then we've got the oxygen and air blender and the flow meter. Okay, and this basically is connected to the humidifier, and the one of the tubings will go to the the air and oxygen port, and the bag which is attached here is the humidifier bag, the saline bag. Okay, so oxygen is being titrated based on the flow meter, and depending on what FiO2 you want, that is the fractional inspired oxygen, you mix the air into this blender. Okay, so the maximum capacity is up to 70 liters. Suppose you put the flow meter to 70 liters, because that is the maximum capacity. The air which is delivered contains all oxygen and no normal air, so it is 100% that time. And as you bring down the flow meter, and depending on how much flow you want to set, the mixture will be decided, and that will decide your FiO2. Okay, I hope that is clear. Okay, so depending on how much oxygen you keep on the flow meter and how much flow you want to keep, accordingly the FiO2 will change. Okay, so if you want a flow of 40 liters and you keep the FiO2, the oxygen flow meters to 40, you will get 100% oxygen. Okay, if you keep the flow to set to 30 and you keep the O2 flow meter to 30, you will get 100% oxygen. But if you keep the flow setting to 30 and you keep the the O2 flow to 10 liters, so 10 liters is oxygen and 20 liters is air, and this will blend and it will work out the FiO2, because your air will also have 21% oxygen, 21 and 100, and then it will average it out. Okay, so that is how the flow and the oxygen, the FiO2 settings are adjusted on HFNC. So what are the basic principles of use of HFNC? Humidification and warming. So it provides warm humidified air, which is closer to what you would normally have compared to the other non-invasive ventilation strategies. It is more comfortable, more tolerant, and it reduces the subjective feeling of dyspnea and the respiratory. Okay, it takes away that work of breathing. Delivery of high fractional inspired oxygen. So as I was saying, that normal flow devices, if you look at your O2 flow meters, it will not give more than 15 liters. But on this, you can go up to 60 to 70 liters. So as I was explaining in the previous physiological discussion, when you have a high inspiratory flow rate, when the person is breathing very fast, is drawing up more air, so you've got entrainment of air which mixes up with the oxygen delivery device which you use like nasal prongs or face mask, and it dilutes your oxygen, so you limit the FiO2 delivery. But with HFNC, you are able to match with this flow rate, and therefore you are able to deliver a higher FiO2, close to 100%. So dead space and PEEP. HFNC will provide an anatomical oxygen reservoir within the nasopharynx. So as the air is being pushed in under this pressure and flow, it creates a sort of bubble behind your nose and mouth, and that kind of works as an oxygen reservoir. It is sort of similar to having the NRBM, the reservoir bag, but it is inside you. And if you keep your mouth closed, then it will also deliver you a PEEP effect. So it will open up the airway, reduce the airflow resistance, and therefore reduce the work of breathing. What are the indications? So definitely acute hypoxemia, that is low oxygen, difficult airways. Wherever we find difficult airways, we want to intubate. It is a device which we can use to buy us time. It is also said to improve gas exchange post abdominal and cardiac surgery. So post extubation, we can extubate people on HFNC in post extubation immediate pre intubation period. So optimizing the patient before intubation and trying to prevent any extubation failures, this device can be used. And sometimes to facilitate bronchoscopy when the patient's oxygen reserve is less. So this will also be helpful because you can continue delivering the oxygen without interruption compared to any other device like the face mask or the NIV. You have to interrupt them. So acute hypoxemic respiratory failure, the evidence comes from this large trial which was conducted and published in 2015 called as Florali study, which which sort of pointed us in direction that HFNC can be used in ARDS, moderate ARDS, mild to moderate ARDS, and it has shown that it prevents progression to intubation and even faster recovery, lesser hospitalization, ventilator-free days, etc. Reduce intubation requirements in patients with non-cardiogenic ARF. The PF ratio less than 200 is moderate. Reduce mortality. So it has come, from 2015, it has come way too much into the forefront in managing ARDS or hypoxemic respiratory failure, at least in the moderate category. So airway management, it can be used for pre-oxygenation. It increases our apneic window. So difficult airways, bariatric cases, obstetric cases, septic patients, awake fibro-aortic intubation, these things can provide up to 15 minutes of apnea. But you have to keep in mind that the CO2 can rise and it can sometimes be dangerous. But it is something which helps us to have enough time, avoiding cardiac arrest while we are dealing with the airway. Extubation and post-operative use, it is common in major abdominal and cardiac surgery patients to have post-operative hypoxemia. So increase the FiO2 is useful but does not address the baseline issue, which is the atelectasis. So HFNC will provide PEEP and it will reduce the need for CPAP uh, via the face mask interface and reduce intubation rate. Many people will not like to have the BiPAP mask, on their face because it is very, very cumbersome and claustrophobic. And HFNC is something which can be used and is helpful in this scenario. There was one study conducted on this particular subject as well, OPERA trial, which basically should, said that very convenient from the patient's perspective. Other uses, as I said, is bronchoscopy in critical care. The patients are borderline, they're hypoxic, and it will help us. Palliative care, yes, we have actually used it in COVID patients with, elderlies who are not for escalation to ventilators as a means for palliation, because the BiPAP is very, very, sort of distressing for them. So HFNC has provided more comforting way for people to be managed, and it is also something which can be looked into home therapy for COPD. Contraindications are same like NIV. So type 2 respiratory failure, we don't use it. It's primarily hypoxemia, but should not delay any mechanical ventilation. Any contraindication for the application of PEEP, it should not be used to reduce level of patients who are unconscious or uncooperative, patients having facial injury, epistaxis or airway obstruction. This device should not be used. And sorry, I've extended my time by a few minutes, but this is how the patients look, much more comfortable sitting out in chair, and the therapy is still going on. Thank you so much. Happy to have any questions.
Thank you, Dr. Vaiti. If anybody has questions, they can type in chat box. We will take it later. We will have now Suchitra.
A very good afternoon to all of you. So as Dr. Vaiti sir has already discussed with you all various benefits of HFNC and what is the mechanism of action, I would basically be showing you the demonstration of the same. So what are the articles required, how you will set up the HFNC machine and start the process. So for the same, I will show you a video which I have recorded. very important. So we go to the patient and explain him that this therapy will help him to meet his oxygen requirement and improve his saturation, as well as it will help him to reduce his respiratory efforts. But once that is done, you will ask the patient to express his doubts. Once his doubts are clarified, then we can move on with the article preparation. So what are the various articles that are required to put a patient on HFNC therapy? First and the foremost thing is the HFNC machine. So this is Airvo 2 humidifier, which is integrated on a portable stand. So this stand consists of the oxygen flow meter as well as the oxygen flow meter, and thus providing this therapy at the bedside becomes very easy as it is portable. Then the other things required are a sterile water of 1 liter. Here we use sterile water of 3 liters so that the nurse need not waste time in changing the fluid. Next we require is a chamber kit. So this chamber kit consists of a water chamber and a breathing tube. Then there are various patient interfaces. Depending upon the patient, whether he is a pediatric patient or a adult patient, you have different patient interfaces. This junior nasal cannula, which comes in different sizes, that is small, medium, large, XL, and then have the adult nasal cannula, which also comes in different sizes like medium, small, large. Then the next thing that we require is a O2 tubing to connect the machine to the O2 source. So these are the few articles that you require when you have to start the patient on HFNC therapy. Now let's see all the articles and how to attach the same to the machine. So first we will attach the O2 chamber, water chamber. So you can see this is the water chamber and the breathing tube. So this water chamber comes with a tube which we attach to the sterile water, and you can see there is a dark line on this water chamber. So we have to see to it that the water chamber is never filled with water above this line. And then how to attach this water chamber? So you get these two ports with your water chamber. You have to fix them onto the water chamber like this, and then you can see there is a slot on the humidifier machine. You have to slide the water chamber inside that slot. So just pull this thing down and slide the water chamber inside, and coincide the two ports of the water chamber with the two ports which are there on the machine, and slide the water chamber inside. Till you hear a click sound. Once that is done, then you will attach the tubing to the sterile water. So just attach the sterile water and hang the sterile water bottle on the stand. Next thing that you will attach is the O2 tubing. So just keep the O2 tubing. One end of the O2 tubing goes to the flow meter, and the other end goes to the coincide these two cords which are there on the upper side of the port with the 2 points which are present on the machine. And you will hear a click sound. Once that is there, it ensures that the tubing is properly fitted into the machine. Now we will attach the patient interface. Now here I am using a pediatric nasal cannula. So just insert it inside, and once again you will hear a clicking sound which will ensure that the cannula is properly fitted into the tube. Now we will attach this to the patient. Secure it properly. Place the cannula, and you can just fit the tubing to the bedding so that it doesn't fall down. So this is how you will connect the HFNC machine to the patient. Now, how the machine works? So you can see. First, ensure that your machine is connected to a O2 source and your machine is connected to a power supply. So how this machine works? You can see there is a filter behind the machine, okay, and there is a motor inside. Now the motor inside draws normal room air and the oxygen from the oxygen tubing inside the machine. Here inside the machine, the mixing of the oxygen and the room air takes place. Now this mixed respiratory gas comes into the water chamber through this port. Here, when the machine gets started, the steel plates start getting heated up, and in turn it heats the water which is present in the water chamber. Thus, the respiratory gas which enters inside gets humidified. That is, the oxygen gets humidified. Then this humidified oxygen enters this port, and from this port it enters into the breathing tube. Now this breathing tube, from this breathing tube the humidified oxygen goes to the patient cannula. Now here you can see inside the breathing tube there is a blue color coil. Now what is the function of this blue color coil? pediatric mode, as my patient is a pediatric patient. Now, if you have to change the mode of the machine, then you have to press this menu button. So once you press that, you see the junior mode is going off and the new target, the machine is asking you to set new targets. So this is the temperature. Just press these two up down buttons simultaneously and you can change the temperature ranging from 31 to 37.
Chitra, we are not able to hear you, dear. Your audio.
The temperature. Then once you are done, again press the menu button and the screen gets locked. Now for next setting, again press the menu button. And then again to unlock the screen, press these two buttons and you can change the flow up and down. And then again just press the menu button and lock the screen. Now the next setting, that is the FiO2. Now this FiO2 value you are supposed to changes when you increase or decrease the oxygen flow on the flow meter. So once you increase or decrease, the FiO2 value in the machine starts changing. Once you decrease the flow, the FiO2 value also reduces slowly. So these are the three settings that you do in an HFMC machine. One is the temperature, as it provides a heated oxygen. Then is humidifier, so you and high flow rate. So flow rate, FiO2 and your temperature. These are the only three settings that you do in a HFMC machine. Now once when all the settings are done, just press the menu button and you will get a tick sign on the machine. That means your settings are done and now this therapy will be started for your patient. Now when you are taking care of patients, there are mainly two types of alarms that will come on for your patient. One is the block alarm. As we have already seen when I was setting the patient, the various targets for the patient, we got a block alarm. So that is the block alarm that we get. So to resolve that, you have to see your tubing, whether there is any kink, whether the patient has any secretions in the nose region, or whether anywhere the cannula is getting blocked. Then once you resolve the blocks, the therapy will again be started for the patient. The next alarm that you get is a leak alarm. So, So from the video, it is clear that what is the settings or how to attach various things, various articles to the machine, and how does the machine works. Now, basically regarding the disinfection, so for disinfection, this is the tube which we get with the HFNC machine for disinfection. What you are supposed to do is there are those two ports in your humidifier. Just block one of the port and one port will go to the top and the other will go to the other port which is there on the humidifier, and you have to just on the machine. The entire process just takes about 1 hour. Once that 1 hour disinfection is done, the machine will be again used for the patient. Next is when to discard these articles. So the sterile water which you are using for the patient, you have to discard this after 24 hours. Then the water that you are various patient interfaces that you are using, that you are supposed to change in every 7 days. So this is all about the machine. Now about nursing care. So the various basically impaired breathing pattern, risk for impaired skin integrity and anxiety are the various nursing diagnoses which we make for these patients. Now overall, what would be the nursing responsibility that nurse has to take care when she is taking care of a patient on HFNC is first is continuous monitoring. Now what is the thing that she has to continuously monitor for this patient are his vital signs. In vital signs, basically the respiratory rate, the saturation levels, keeping a watch on them is very important. Then keeping an eye on patient's ABG values. Then once the therapy is started, keeping a watch on these things and the patient's respiratory effort is important, so that whether the therapy is being effective for the patient or not, that we can understand from these values only. If in case the patient is not improving, that means we have to change the settings, or we have to go for any other alternative, that is putting the patient on ventilator. Hence, the nurse who is taking care of patient on HFNC, she has to see to it that she keeps the intubation trolley ready and a ventilator is also kept ready, so that whenever needed, we can put this patient on ventilator and intubation things are also kept ready. Next thing is keeping an intake output chart updated is also important, because keeping an account of patient's nutritional requirement and keeping him or her hydrated is very important. Other than that, assessing patient's skin status. So we are continuously keeping the nasal cannula in place. That is why we have to watch for any skin integrity impairment. So keeping a watch on the patient's nostrils and as well as at the ears where we secure the nasal cannula is important. So padding these areas with various materials which we have as per the hospital policy is important, and frequent skin assessment is important. Then as other than that, encouraging the patient to expectorate if there are expectorations, and if secretions are then using suctioning method to remove the secretions is also important. Other than that, helping the patient to do deep breathing exercises whenever possible. And other than that, the benefits of HFNC, as we have already seen all the pictures which Dr. Vaiti had showed you, where the patient was happily having his meals, drinking water, so which is not possible with normal NIVs. So that is the reason this instrument is very patient friendly, as well as very much easy to handle for nurses as well, because just with 3 settings we can prevent a patient to go on ventilator as well as provide with maximum oxygen on a very high flow rate. So I hope so this session was informative and you have your doubts are being clarified. If anything is, then the session is open to you all and you can get your doubts clarified. Thank you, ma'am.
Thank you, Suchitra. I think there was one question which the candidate has asked, the positioning that is to be given during hyponasal cannula therapy, whether it is Fowler's or any position that can be given.
So basically it is propped up position. So 30-degree propped ups is necessary. But apart from that, the patient can be seated in Fowler's to high Fowler's position. He can be chair seated. Even he can walk during this therapy because the stand is portable. So we usually don't give these patients bedpans or everything. We give commode chair to them to they get up, they sit on the chair, their elimination needs are met, and thus keeping the patient confined to bed is prevented from this therapy.
Thank you. I don't see any more questions in the chat box. I think Dr. Vaiti and Suchitra has wonderfully covered. And I especially thank Dr. Charudat Vaiti. You took interest in sharing case studies, making it so interesting. I'm sure delegates have benefited looking at, what results we got. And I must say that you were explicit in explaining the basics. Similar way, Suchitra has really taken effort to explain each and every step with high flow nasal cannula therapy, and I'm sure the delegates will benefit. Next time they will see that, they will say, yes, I know this. Just to add to this, the nursing benefits, I had gone through one study about high flow nasal cannula. So they have explained 3 things. The results were, first, most of the patients, those are with severe critical disease, are elderly patients. And they, especially in COVID-19 time, they were not allowed to come with the family. We had uniforms, which patients would get scared if they are not able to see the caregiver, the healthcare professional. It was adding to their anxiety. And claustrophobia, which was caused by non-invasive ventilation, it can worsen the situation. So this high flow nasal cannula has really come to our rescue to put them at ease. Secondly, the study also brought out the man-machine cooperation. We saw in NIV there is a lot of man-machine cooperation is needed, which may be difficult with elderly patients. And the extent of cooperation that directly affects the efficacy of oxygen therapy, which also is being taken care with high flow nasal cannula. And third, the number of patients which increase rapidly. So this high flow nasal cannula actually gives a ease of, it's user friendly. As Suchitra mentioned that, once we learn it, we will be able to do it at ease. So this will provide again confidence to healthcare professionals that we don't have to depend on special respiratory therapists who would come and put it for the patients. So I'm sure the delegates have taken the message with high flow nasal cannula that it does provide us a specific positive end expiratory pressure, which will help us in respiratory failure. And second important part is adequately warmed and humidified oxygen. Humidified oxygen through nasal pharynx. And as Dr. Vaiti explained that it will provide a reservoir. So with all those details, I'm sure the delegates which are there on Zoom, we have 98. And on YouTube, there are more than 90 people, as live streaming is on. And I'm sure this particular webinar has benefited many. I'm still trying to see if there are any more questions on the chat box. I think somebody asked about the e-certificate. We will be mailing you. So please put your email address when you share your feedback. It will, it will help us to send you the e-certificate. Second announcement which I have for the delegates is, please, if you can subscribe to YouTube channel, it will be easier for our forthcoming programs for you to log in. And with that, I would like to put a quote here. Never lose an opportunity for urging practical beginning. This is from Nursing Notes by our dear Florence Nightingale. However small, it is wonderful how often in such matters the mustard seed germinates and roots itself. So I think from CCNS, we made this effort. We came up with these need of the hour, these 2 devices and also the nursing care. And I think both the teams from Saifi and from Fortis Mulund, they have gone in depth, not only the nursing care, but also the cleaning aspects were explained. And with that, I'm sure the delegates were very satisfied. I don't see any more questions. I think there was one question about there was one question which was not clear. I have replied. I'm sure that delegate will answer if it is still not clear. And if there are any more questions, you all are free to ask. If any CCNS member wants to add anything, we are really on time. Everybody has kept with time. I must appreciate that both the teams were very much on time, and even the delegates, one little bit disturbance here and there. Otherwise, we had a very, very, disciplined delegates, and I'm very happy. All the delegates, really kept whatever housekeeping request we gave in the beginning. If any CCNS executive member would like to add anything before we end this webinar, you all are welcome to do so.
Yeah. Hello. Hello.
Yes, Belinda.
Yeah, am I audible?
Yes, you are audible.
Yeah, just one suggestion to all the delegates. If there are any learning needs, as we have presented today on this skill based on respiratory devices, if there are any other learning needs which they feel, we could have some more webinars on skill based needs, they could, get back to us and we will try to organize. Hello?
Already there is an request that we look forward learning more skill bus webinar.
Yeah.
So
Yes.
very happy
So
to know.
if they could specify the topics to us, that would be great. So it's easy for us to go in that direction. Thank you.
We still have a few minutes. If there are any more questions, we welcome if you can type in your chat box. We
Yes,
have our experts
one
waiting.
more thing, Prajakta, I'm sure ma'am Jaya must have mentioned, but if we could appeal to the delegates to be life members of CCNS, they can join us as CCNS members.
I'm sure there are many experts who are attending, and you could be the one, sharing your expertise with young nurses. This is our effort, but if you join the team, it will be benefiting to all with whatever skill base people are looking for. I think people are looking for a combination of theoretical and skill base. I'm just looking at the chat box and get, what delegates would like us to do. ABG interpretation requested by Irene Light. Surely, I think very good, very encouraging. The delegates are really connecting and voicing out what they would like to have. We will surely plan in our future skill-based webinar about ABG interpretation. Dr. Jaya, you have anything, madam? Jaya, madam? You want to say something since we have time?
I just wanted to conclude in continuation what Belinda said and what I said in the beginning. We will definitely look at having more skill-based webinar, but at the same time, the society needs to be strengthened, and the strength of the society is its members. So if we could have more members, we can even have different chapters. So we could conduct these smaller programs under the umbrella of chapters or by CCNS central body itself. So my request to all the delegates who attended today, if you are not the member of the CCNS, kindly become member. And those seniors, I'm not able to know who are the seniors who attended the program. Kindly take initiative to start the chapters, and those who are academically oriented, please start writing to the journal, which is going digital and which will get indexed soon. And of course, as per your request, we will consider conducting more and more skill-based webinars in future. Thank you for your participation. Thank you, Saifi and Fortis team. Thank you, Prajakta, for that wonderful moderation. Thank you, everybody.
Thank you, madam. I think we already got topics for our next skill base. ABG is there, ECMO is there, plus I see pediatric early warning signs. It's wonderful to get and very, very encouraging delegates. So I thank delegates. I thank our CCNS team for taking the initiative, and both the teams were wonderful. And I think we can conclude the webinar, and we will be coming out with more skill-based webinar in the future.
Prajakta and ma'am, if we could again emphasize to all the delegates to go in for ICU accreditation by CCNS. I think that would be a good initiative by the concerned organization. Ma'am, if you could again mention about the accreditation of ICUs. Or Prajakta, you can.
Yes, we have CCNS standards, which were very thoughtfully done by experts, and we expect that the delegates should come up with, with the desire to get their ICUs accredited, and ensuring that we keep the highest standards. And these CCNS standards are made for Indian ICUs, taking in consideration how the Indian nurses strive or, work hard. And this particular accreditation will be a feather in cap for many hospitals. So we urge you, go on our website. If you really have desire, we can share our standards. You can have a self-assessment done, and then, you can enroll for getting this accreditation done, which will be in long term, will help you maintaining the high standard of ICU nursing. If there are no more questions, I think we can announce that webinar is concluded. Anybody has anything to add?
I think we can conclude.
So thank you once again, all the delegates, Team Fortis and Team Saifi. Really, it was a wonderful webinar to start with, and I'm very proud to be associated with CCNS. Hopefully, we'll have our next webinar soon, and it was a, very, very quick response by so many delegates. We hope to see all of you there. Thank you once again. Have a wonderful evening and a wonderful weekend. Thank you.
Thank you, Prajakta.
Mini, good job.
Congratulations all. Well done.
Thank you, madam.
Best part is no delegates left. It was always 99 and 100. So people were glued. So that this itself is an encouragement that, nobody wanted to leave in between. Normally in webinars, we see beginning there are many delegates, and by the time it is halfway,